Today we're going to talk about blood pressure and how to measure it, some common pitfalls. Blood pressure is a common vital sign that we take on every patient, and we monitor how blood pressure changes while we're taking care of them. So let's start with the idea of blood pressure. Blood pressure is the amount of pressure placed on arterial walls when the heart is contracting or at work, and when the heart is relaxed or at rest. The terminology we use for the heart contracting or working is systolic. So the systolic phase of blood pressure is when the heart contracts and blood moves out of the heart and into the arteries and vessels with pressure behind it from that muscular contraction. Diastolic is the term that we use for the phase when the heart relaxes and there isn't increased pressure against those vessels. A bit of a different visual. So diastole is the vessels at rest. There is always an amount of pressure in the vessels, even when there's not a contractile force behind it. There's always blood in those vessels, and they exert a certain amount of pressure on the vessel walls. But in our systolic phase, or systole, when the heart is contracting and working, there's an increased amount of pressure against those vessel walls. So how do you report blood pressure? It depends a little bit on how you take it, and we'll discuss a couple different methods of acquiring a blood pressure. But we record generally the systolic pressure over the diastolic pressure. And the systolic pressure, because it's the heart at work, is always going to be a higher number, a higher pressure against those vessel walls, versus the pressure of diastole, or the diastolic pressure, the amount of pressure against those vessel walls while the heart is at rest, is going to be smaller. And we report it systolic over diastolic, or the higher pressure over the lower pressure. And we're measuring that pressure in millimeters of mercury with the equipment that we use. So what are normal values or healthy values? We generally consider a healthy blood pressure to be around 120/80. We do have some general increase in blood pressure as we age, because for all of us, whether we have heart disease or not, all of our vessels become less elastic as we age. So older people generally have higher blood pressure than younger folks. But normal values we consider 120/80 or less. When we start talking about hypertension, we think about systolic of 120/139, over a diastolic of 80/89. If you have a resting blood pressure in those ranges, physicians tend to think that you have pre-hypertension. As those numbers get higher, you have levels of hypertension. And again, these blood pressure values are resting blood pressure. In the field, in EMS, we often see systolic blood pressures that are above 120, because people also have a higher systolic blood pressure when they are stressed out or in pain, which many of our patients are. So these values refer to resting blood pressure. So how do you measure blood pressure? There's a variety of steps that we'll go through, and we'll talk about each one and why they're important. So we'll talk about the equipment that we'll need, how we place that equipment on the patient, specifically how do we align it so we get the most accurate value possible. What position do we want our patient in so we get, again, the most accurate blood pressure that we can have. And the steps involved in blood pressure measurement. How do we figure out their systolic and their diastolic? How do we obtain those values? What's the difference between palpation and auscultation, a palpated blood pressure versus an auscultated blood pressure? And what are some sources of error? How do we do this and get inaccurate blood pressures? So first of all, let's talk about the equipment. There are two main pieces of equipment to take an auscultated blood pressure, and that is a sphygmomanometer, or a blood pressure cuff, and a stethoscope. Auscultating a blood pressure is when we listen to the blood pressure. So in auscultation, the stethoscope is a required piece of equipment. However, we can take a blood pressure by palpation, where we obtain our values by touch, and we would only need the sphygmomanometer or the blood pressure cuff for that. How do we want our patient to be positioned for the most accurate blood pressure possible? Well, very similar to this picture. So think about how that patient is positioned, and we're going to talk about the important pieces of this. So we would like our patient to be sitting with both feet on the ground and uncrossed. Their back should be supported. The arm should be relaxed, so no muscle tension, with a slight bend at the elbow. And preferably the arm is at heart level. So if you noticed in that prior picture, the patient was resting their arm on a table that was approximately at the level of their heart. If our patient is lying down, we would like them relaxed, supine, which means lying on their back, with the arm at the heart level. So we're not going to be holding their arm up in the air. It needs to be along the plane of their body. Generally speaking, we would like them to not be talking and be resting or calm for about 3 to 5 minutes. So this is not somebody who just ran in or has been very excited, that they can be calm and taking some nice deep breaths for about 3 to 5 minutes. If we need to repeat blood pressures, we prefer to wait at least 1 minute between measurements on the same arm. Otherwise, taking blood pressures in rapid succession can really affect the numbers that we get. And we want to establish a baseline to compare over time. Remember, these are our ideal conditions for taking accurate blood pressures. So how do we measure it? Well, we need that dial on the sphygmomanometer, on the blood pressure cuff. We'll talk in a moment about how that cuff is placed on the body, but for now, let's take a peek at that dial. We've got a whole bunch of numbers that represent millimeters of mercury of pressure. We inflate that cuff to around 190-ish. We can ask our patients if they know if they have high blood pressure. If they know their normal blood pressure, that can determine how high we inflate the cuff. If they say their normal blood pressure is around 100, their systolic pressure, then I'm probably not going to inflate the cuff to 190. But if they say their normal blood pressure is around 160, I might inflate it a little bit higher to make sure I catch that top number, that systolic blood pressure. So we're going to inflate the cuff, and then we are slowly going to release the pressure with a dial that's on the bulb that we use to inflate it. I like to refer to that little dial as something of a stick shift in a manual transmission for those of you who have driven stick shifts. Every clutch engages a little bit differently, and with every blood pressure cuff, that dial comes down at a slightly different speed. So you have to have a sensitive touch on the dial in order to get a nice, smooth descent of that needle as it comes down. Now, if we're taking the blood pressure only by palpation, we're going to have our other hand on the patient's radial pulse. And the first time we feel the pulse, that estimated systolic blood pressure by palpation in step 1 is probably going to be a little bit higher than where we would hear it by auscultation. So as I release that dial, I have my finger on the pulse. The first time I feel that pulse, I'm going to record that number and completely deflate my cuff. And now I have a blood pressure of systolic by palp. So I'll write down that number. Let's say it's 148/P for palp. Now, if I'm taking it by auscultation with a stethoscope, I'm going to wait for the first sound that I hear. So as I deflate that cuff and slowly open that valve, that needle will come down and I will start to see that needle bounce, and then I will hear a sound. This is our step 3, our phase 1 carotid cuff. I want to record the number that I hear that sound. When you're doing this manually, don't split hairs. Just go for the most even number. So I wouldn't record a 147. I'd either record a 146 or a 148, for example. So the first time I hear the sound, I want to tuck that number away in my memory and then continue to let the needle slowly deflate. And I'm going to have to adjust the valve to make sure it does this at about 2 millimeters per second, which means I want a nice steady rate of drop of that needle. And I'm going to continue to hear those sounds. I'm going to hear it, I'm going to hear it, I'm going to hear it, I'm going to hear it. And it's going to get quieter. And the last time I hear that bump, that step 4 or phase 5 carotid cuff, that is my diastolic number. So it's a little bit of a skill building piece to realize where you last heard this sound. Once you hear the last one, let it deflate a little bit more to make sure, and then completely deflate the cuff. So what are these carotid cuff sounds that we're talking about? Well, carotid cuff was a doctor from Russia who first discovered the sounds of blood pressure with a stethoscope. So when you inflate the cuff to 180, 190, 200, depending on your patient to some extent, we start deflating the cuff and we're going to see that needle bounce, and then we're going to hear a noise. And carotid cuff sounds have different phases, which you might be able to discern, especially as you get more experience and more practice. Your ears will start to tune in to the different phases of these sounds. The first sound is pretty loud and is described as a tapping sound. And then as that needle continues to deflate, continues to decline, it turns into a soft swishing sound, then to a crisp sound, and then to a blowing sound, which we really need to tune in to hear as much as possible. And then we stop hearing the sounds of the blood pressure altogether. So that's what carotid cuff sounds are. I liken taking the blood pressure to releasing water from a dam. We're damming up the artery with that blood pressure cuff. So we're not going to hear anything initially because there's no blood flowing, there's no water flowing south of that dam. As we slowly release the dam and release water, initially there's that flood of water coming through, or blood coming through the artery. So it's going to be very distinct to begin with. But then as we release more water, it becomes a more gentle flow, and the sounds of that rushing blood become a little bit less and less until there's no real pressure behind it from that dam anymore. And then we're just going to hear the blood pressure, the pulse of the heart. And then as it becomes a more laminar flow or smooth flow, we won't hear those sounds of pressure anymore. So let's think about some potential sources of error. So go ahead and grab a sheet of paper and a pen. And I want you to think about these following pieces of patients not positioned properly, or maybe we're not applying the equipment appropriately, and think about what this may do to the blood pressure. Does it make the systolic pressure go up or down? Does it make the diastolic pressure go up and down? Is it going to be accurate, and how is it going to change it? So do you think that the patient not resting for 5 minutes, so they just got in that car accident and we got on scene and they're pretty excited, they have a pretty big sympathetic nervous system response from getting in this car accident, What do you think that's going to do to their pressure, to their systolic and or their diastolic pressure? Is it going to make it go up or go down? The same question with if they've just drunk a bunch of coffee or smoked a cigarette. How do you think that might affect their blood pressure? What if the patient has to support themselves or is kind of slumped over where they have to hold their own body erect? How is that going to affect their blood pressure? If they have their legs crossed or even their ankles crossed, how might that affect their systolic or diastolic pressure? If their upper arm is held high, this sometimes happens when we have a patient lying down and we hold their arm up in the air to take their blood pressure. How is that going to affect our accuracy? Or if they're sitting up and their arm is just hanging at their side, how might that affect our accuracy? If their forearm is not supported, so they're holding their own arm up in space. And if we place the bell of the stethoscope underneath the cuff, how might that affect the accuracy of our blood pressure? So let's see how you did. So our patient not resting for 5 minutes tends to cause an increase in both our systolic and our diastolic pressures. If they've just had a bunch of coffee or smoked a cigarette, it does the same. It tends to increase the systolic and diastolic pressures. If the patient is supporting their own weight or slumped over, it tends to cause an increase in their systolic, up to 6 millimeters of mercury. So maybe their actual systolic pressure is 120, but you measure it as 126. If the patient has their legs or ankles crossed, which we commonly do, and as providers, we need to catch that because the patient won't, it tends to cause an increase in systolic blood pressure. If we have their arm up above their body, increases their systolic blood pressure. And if it's draped down below, it decreases it past their normal. If they're holding their own arm up and we're not supporting that arm or a table, it tends to cause an increase in systolic. And if we place the bell of the stethoscope underneath the cuff, it's often challenging to hear those Krakow sounds as clearly. And especially when you're just learning how to hear those Krakow sounds, we want all the advantage in our court. So we don't want to place the bell of the stethoscope under the cuff. So just a little bit of terminology. Not all stethoscopes are created equal. So this is one that has both a bell and a diaphragm. Generally speaking, in EMS, we use the diaphragm side. And with stethoscopes that are shaped like the one in the picture, that bell and diaphragm will actually twist 180 degrees. So you twist it one way and you're going to be able to hear through the diaphragm. You twist it the other way and you'll be able to hear through the bell. So make sure you're on the right side to be able to hear. The bell is often used in pediatric patients or to hear heart tones a little bit more specifically. So we're often using that diaphragm. And placing the diaphragm underneath the cuff would have those same results as placing the bell. Here's some more issues to think about. So if we push up the patient's sleeve and it's tight around their upper arm, how will that affect our reading? If the cuff is too small, so maybe we're using a standard size cuff on somebody with a really big bicep, or the cuff is too large. I see this a lot with our geriatric patients where we grab that standard cuff that's always accessible, and it's just too big for their little tiny arms. If we apply the cuff too loosely, which means it's sliding off all by itself, or it's too tight, it's already constricting the arm. The bladder is not aligned over the artery, and on most cuffs that we use, there is an arrow that indicates the artery. And that will cover a little bit more specifically in lab of where to find that artery on the medial side of the upper arm. If we deflate the cuff too fast, so that needle comes down too quickly, or it's too slow, so it stalls out maybe. Or if we apply that stethoscope too firmly, we're pushing it into the skin. How do these things affect our measurements? All right, let's see how you did. So constrictive clothing, pushing that sleeve up nice and tight, causes a decrease in the diastolic blood pressure. So instead of getting a diastolic blood pressure of say 80, you end up getting a diastolic blood pressure of maybe 76 or 78. If the cuff is too small, first off, we often know that the cuff is too small where as we inflate it, the Velcro starts to pop, and sometimes a cuff pops off completely before we can get it snug enough. But if it's too small of a cuff, it causes an increase in systolic and diastolic pressure. And if the cuff is too big, it causes a decrease in systolic blood pressure, which means, again, we're measuring their systolic blood pressure lower than it actually is. So let's look a little bit at cuffs for a moment. So cuffs come in a variety of sizes. Generally, we use an adult cuff, but there are large adults. There's also adult longs where it's the same width of cuff, but it's a longer cuff. We have thigh cuffs, we have pediatric cuffs, we have infant cuffs. And when you open them up, for the majority of them, they have a measurement rating inside. So they've got a line where the lines need to be, when you place the cuff over the upper arm, those measurement lines need to be congruent. So often you can tell right when you put it on whether it's too big or too small. All right, how about that cuff being applied too loosely, where it's just falling down their arm? Causes an abnormal increase in systolic pressure. If we put it on too tightly, a decrease. It should just be snug. Snug enough where it stays on the arm and doesn't fall off, but isn't constricting to begin with. If we don't align the bladder over the artery, it tends to cause an increase in both systolic and diastolic pressure. We're just not reading it accurately, and we're not squeezing that artery as accurately as we could be. If we deflate the cuff too fast, so that needle comes flying down the dial, then we're not going to catch where those numbers should be. We won't hear it until the needle's already past that millimeters of mercury where it actually is. If we inflate it too slow or inconsistently, can cause an oscillatory gap. So a decrease in systolic and or an increase in diastolic. So it just changes, again, those numbers of where they actually should be. And if we're pressing that stethoscope hard against the skin, it actually causes a decrease in our reading of a diastolic blood pressure. So how much change are we actually talking about? So if the patient is talking, so maybe you're taking a blood pressure while somebody else is taking a patient history, it could cause a change of up to 10 points on both our systolic and our diastolic. If the bladder is distended or overinflated, can cause a discrepancy of 15 and 10 points respectively for our systolic and diastolic. Cuff over clothing could have a huge effect or a fairly minimal effect. Generally, we talk about we can place a cuff over one thin layer. So if they have a long sleeve t-shirt on, that's generally okay. Placing the cuff over a sweatshirt or a jacket is not okay. You're just not going to get an accurate reading. So think about the clothing and can we move it without causing too much constriction? Coats need to come off, and we may be doing it by palpation if we're taking it over a thin layer. If they have smoked within 30 minutes of taking their blood pressure, it could cause a drastic range of change. It's challenging. If they're sitting with their back unsupported, Again, it could cause a big range. Or if their arm is unsupported, again, there's a pretty big range in there. And if they're standing, it can actually be increased. Sometimes with our patient populations in pre-hospital medicine, we don't have as much choice in the matter of getting the most accurate resting blood pressure that we can. We can't control whether or not they've been smoking. Sometimes it's challenging to get arms supported or get them in the most ideal position. But understand that the things that we've talked about here are really the most ideal, and we should strive to meet those ideals as much as possible to make sure that we're getting as accurate a measurement of blood pressure as possible, especially as we trend that vital sign or repeat that vital sign over time to see how it changes while we're with our patient. We want to know that change is due to their condition or our treatments, and not just because we're getting inaccurate readings because of how that patient is positioned or how we've positioned the equipment. All right, so let's test your understanding of this. What is wrong with these following pictures? And hopefully you came up with her arm is not supported. He obviously has her at the wrist, but not at the elbow, which means she has to hold that arm up in the air. And these are actual pictures taken from sites that talk about taking blood pressure. So it's pretty interesting that they're not showing accurate depictions. And again, here, that arm isn't supported. They're actually almost flexed, holding their arm up in the air, and it's definitely going to increase that systolic pressure. So in this case, the arm is supported, but it's almost hyperextended. It's completely straight, and we'd like to have a little bend in that arm. One trick that some providers will do is to actually take the patient's hand and tuck it in their armpit so they can support the hand while supporting the elbow as well in a slightly bent angle. So in this picture, the arm is supported, it's slightly bent, it's at the level of the heart, but that patient is slumped forward. Their back isn't supported against the chair. And again, this patient is holding their own arm up. It is not supported at all. So in this picture, the diaphragm is against the skin, but the edge of that bell is tucked underneath the cuff, which can make it challenging to hear the sounds, the carotid cuff sounds, or the sounds of the pressure accurately. And as we talked about earlier in this presentation, that systolic over diastolic, the heart at work over the heart at rest. The heart at work is going to be the larger pressure. The heart at rest will be the less pressure. So the bigger number should be over the smaller number. This should be reported as a 120/80 for an auscultated blood pressure. Well, I hope this makes learning of the skill of taking a blood pressure a little bit more straightforward. And I hope you look forward to learning this skill in lab.